So what is the pathophysiology of the stroke is formation of an atherosclerotic plaque. So once there is an atherosclerotic plaque formation, it results in formation of thrombus load, which further hampers the blood supply towards the distal to the thrombus. Or it can be a simple cardioembolic stroke, especially seen in a patient with valve replacement or prosthetic valves, in a patient with arrhythmic events, in a patient with chronic AF or other things, or in a patient with VFVT. You do find cardioembolic stroke wherein there is a thrombus which gets lodged up into the cerebral circulation. Or it can be as a part of a septic emboli, especially in infective endocarditis, or your splenic emboli, spleen throwing infarcts up above, or your any infective source throwing infarcts above. Or it can be as a result of microemboli or immune thrombosis, which we saw recently in the pandemic, that is COVID immune thrombosis. Or it can be as a part of any viral inflammatory or autoimmune disease or autoimmune disorders, especially secondary to coagulability disorders causing thrombus formation. So what are the risk factors? Obviously your hypertension, diabetes mellitus, arrhythmias, obesity, OC pill usages, autoimmune disorders, vasculitis, CKDs, hypercoagulable disorders, smoking, IV drug abuses, etc. There are a lot of risk factors, of which uncontrolled hypertension, uncontrolled diabetes, arrhythmias and CKD forms a major part. So how do you do an emergency stroke management? So you know the fast profile. After once you diagnose a patient with stroke, the time is brain. So the most important goal here is to bring the patient to a stroke care unit and to rule out hemorrhage and initiate your thrombolytic agents or thrombectomy, whatever is for the beneficial for the patient. So as per the NINS time goal, they say that as soon as the patient arrives to your emergency department, the general assessment of the patient with stabilization of his airway, breathing, circulation, that is very important, because in case of a massive stroke, patient's airway may be compromised, his GCS may be low, it may be less than 8, or he is not protecting his airway, the chances of pulmonary aspiration are very high. So stabilization of his ABCs, general assessment and ordering for a brain imaging should happen within 10 minutes of arrival to your emergency department. Post that, there should be a complete neurological assessment which has to happen, and his history of the patient should be assessed, like when was the patient last seen better, what happened, how many hours have elapsed, did it happen during sleep, and what were the deficit, is it an old CVA or a new CVA, and all those things. And the stroke should be diagnosed, or at least your neurological dysfunction should be diagnosed as per your NIHSS scale or your Canadian stroke scale. And all these assessments, that is the primary assessment, should happen within 45 minutes from the ED arrival. Then once like patient has gone for a scan, and then after ruling out hemorrhage, patient arrives. So then there is a checklist whether the patient is a candidate for administration of thrombolysis, whether there are any contraindication for thrombolysis, which we'll see in the next slides, and whether patient is suitable in the time frame or in the golden period that the TPA can be administered. So this event should happen within 60 minutes of ED arrival, and post this, the NINS guideline says that within 3 hours of arrival, the patient should be transferred either to a stroke related ICU or a neuro ICU and a post neurological care to prevent secondary brain injury